Weakness in one leg. General features. Is it painful for the patient to move about? In the presence of coexistent back and leg pain, a radiculopathy or plexopathy and sciatic nerve lesion should be suspected. More distal symptoms in the absence of back pain would indicate a more peripheral nerve lesion, e.g. common peroneal nerve palsy. Neurological examination. The back. Check the following. Local tenderness. Consider vertebral collapse or fracture. Paraspinal muscular spasm, in response to pain. Restricted movement. Radiation of pain. Pain radiation in radicular lesions. L2 and L3 pain radiates to anterior thigh. L4 pain radiates through the knee and down the medial side of the calf to the medial malleolus. L5 pain radiates through the buttock, down the posterolateral aspect of the thigh, through the lateral aspect of calf and across the dorsum of the foot to the big toe. S1 pain radiates through the inner buttock to the posterior aspect of the thigh, then through the posterolateral aspect of calf to the lateral border of the foot. Straight leg raising. Unilateral restriction may signify sciatic tension, but may also be limited by pain in the absence of nerve or root compression. Legs. Check carefully for the following. 1. Is there any wasting or fasciculation? 2. Is there any weakness? If so, what is the distribution? Specifically check for lesions of the following roots. L2 weakness of hip flexion and thigh adduction. L3 weakness of thigh adduction and knee extension. L4 weakness of knee extension and ankle inversion. L5 weakness of ankle dorsiflexion, inversion and eversion and dorsiflexion of the great toe. S1 weakness of plantar flexion, eversion and knee flexion. 3. Are reflexes normal? Hyporeflexia or areflexia is only seen with lesions of the following roots. A. L3 and L4, knee jerk. B. S1, ankle jerk. 4. Sensory abnormalities in a well-defined distribution will help with localization, Fig. 8. Peripheral nerve lesions. Common peroneal, or fibular, nerve palsy. Look for evidence of the following. Causes foot drop with loss of ankle and toe dorsiflexion, and ankle eversion. Causes numbness over the lateral aspect of the lower leg and dorsum of the foot. Is usually due to pressure over the fibular head. NB. Differentiation between a common peroneal nerve lesion and an L5 root lesion is a common clinical dilemma. A common peroneal nerve lesion will cause weakness of ankle dorsiflexion and eversion, but will not affect inversion. Posterior tibial nerve palsy, tarsal tunnel syndrome. Look for evidence of the following. Wasting may occur in the intrinsic muscles of the foot, leading to weakness of toe flexion. Causes a burning sensation in the toes and sole of the foot, with reduced sensation on the sole. Entrapment usually occurs behind and below the medial malleolus. Femoral nerve lesion. Look for evidence of the following. Causes wasting and weakness of knee extensors. Results in a depressed or absent knee jerk. Causes sensory loss in the anterior thigh and medial part of knee. May be compressed by a psoas abscess or hematoma, or damaged by fractures of the pelvis, traction during surgery or thrombotic lesions of the vasa nervarum, e.g. in diabetes mellitus. Sciatic nerve lesion. Look for evidence of the following. The sciatic nerve splits to form the common peroneal nerve and posterior tibial nerve, so damage to the sciatic nerve encompasses both of the above. Causes weakness in all muscles below the knee, as well as knee flexors. Causes sensory loss over the lateral border of the lower leg and entire foot, except the medial malleolus, which is supplied by the saphenous nerve. NB. Because muscle groups receive innervation from more than one root, weakness may be minimal in someone with a single root lesion. Thus, in the case of severe weakness, e.g. complete foot drop, a peripheral nerve lesion or multilevel radiculopathy must be implicated. Furthermore, weakness that fails to conform to a simple pattern may be due to a lumbosacral plexus lesion. NB. A common clinical mistake is to expect loss of the ankle jerk with foot drop. If this is the case, it suggests involvement of both L5 and S1. Further discussion. What are the causes of back and unilateral leg pain? There are many causes of back pain. Radiation to a leg implies involvement of nerve root or lumbosacral plexus and limits the differential diagnosis. L5 and S1 are the most commonly affected nerves in degenerative disease. L4 is involved occasionally, but L2 and L3 rarely, and if they are, the diagnosis is not likely to be simple degeneration. Causes of back and leg pain. Radiculopathy. Disc disease. Degenerative spinal disease. Infective spinal disease, pyogenic abscess, tuberculosis. Malignant spinal disease, secondary tumor, myeloma. Intrinsic, e.g. secondary tumor, myeloma. Extrinsic, e.g. extramedullary, nerve sheath tumor, meningeal infiltration. Plexopathy/sciatic nerve lesion. Pelvic retroperitoneal mass. Tumor. Hematoma. Abscess. Hip fracture. Misplaced deep muscular injection. NB. If weakness, e.g. foot drop, is associated with pain and only comes on with exercise, then consider lumbar canal stenosis. In the outpatient clinic, the patient with this history but no physical signs should be asked to walk until the symptoms come on, as this may reveal abnormal signs.